Hello, my name is Karen Effinger, and I'm an assistant professor of pediatrics at Emory University and the medical director of the Survivorship program in the Aflac Cancer and Blood Disorder Center. I'm here today to talk to you about AYA oncology and survivorship. So this talk will follow the topical structure suggested by the ABP, sort of. So we aren't going to be speaking as much about basic science and pathophysiology, but are mostly going to be focusing on epidemiology, risk assessment, diagnosis, management, and treatment. So there will be three components to this talk. We're going to start with AYA oncology, move on to late effects, and then discuss fertility preservation. So when we think about AYA oncology, there are many different definitions of AYA. The NCI definition is a cancer diagnosed between 15 and 39 years of age. For this population, there are approximately 70,000 cases diagnosed each year within the United States. And if you compare that to about 11,000 in our younger pediatric population, you can see that this is a much more common diagnosis in the AYA age range. And they represent approximately 5% of cancer diagnoses within the United States. When I think of AYA oncology, I really think of the different cancers being an intersection between the pediatric and the adult types of cancers. So you can see later diagnosis of some of our more common embryonal cancers of childhood and earlier diagnoses of carcinomas that are more commonly seen in the adult population. However, AYAs also have a population of cancers that typically are diagnosed in that range. So thyroid carcinomas, melanoma, connective tissue disorders, germ cell tumors are more common in this population compared to the older or younger age groups. And when we look at this with more granularity, you can see this is cancer distribution by age. And the younger population, again, is where we see more of our embryonal tumors. And as patients get older, the composition is more likely to start to skew towards the cancers that are more commonly seen in the adult population. So for our 15 to 19-year-olds, lymphoma is the most common type of cancer and diagnosed in approximately 25%, followed by leukemia, sarcomas, and CNS tumors. However, in those ages 20 to 29 years of age, lymphoma is still approximately 22%. However, the next most common are melanoma, thyroid cancers, and testicular tumors. And just to remember that Hodgkin lymphoma is the most common lymphoma in this age group. Why is AYA oncology so important? Part of the reason is because of the difference in survival rate. So there have been overall gains in survival amongst all cancers, but this has been less in the AYA population compared to the other age groups. And we know that relative survival rates are lower in adolescents and young adults for some diseases. And so this is when we compare to younger patients. So in this graph, you can see on the y-axis survival percentage, and on the x-axis age of diagnosis. And you can see for Hodgkin lymphoma, renal tumors, brain tumors, Ewing sarcoma, ALL, and hepatic cancers, the rate of survival really decreases as patients get older. This is also true for neuroblastomas and rhabdomyosarcomas. But for some cancers, it's really the AYA population that has the worst prognosis compared to both younger and older patients. So this is common in breast cancers, colorectal cancers, soft tissue sarcomas, non-Hodgkin lymphomas, and leukemia. Now, this isn't true for all of our cancer types. There is a similar prognosis across age groups for thyroid and testicular cancers, and actually a better prognosis for melanoma. So when we think about a difference in AYA survival, there are different reasons that can cause this survival differential. And there are many different things that we're going to talk about. The first thing that I want to address is cancer biology. So what we know is that for some diseases, there are poor prognostic factors based on the cancer biology. And the most common example that we think of with this is B-cell ALL. So as we're aware, pH positive mutations or translocations 922 are not common in children and occur in less than 3% of the population. However, in adolescents and young adults, that increases to 3 to 26%. The same is true for pH-like disease. So in ages 1 to 9. This occurs in approximately 10% of the population, compared to about 27% in patients that are aged 29 or 21 to 39 years. Similarly, in BALL, patients who are in the AYA age group tend to have, are less likely to have good prognostic features like hyperdiploidy or ETV6 RUNX1 mutations. So for example, approximately half of children have the ETV6 RUNX1 mutation compared to only 10% of adolescents and young adults. In TCL and TALL, HOX mutations are more common. In rhabdomyosarcoma, AYAs are more likely to have alveolar disease and chromosome 13 translocations, which are poor prognostic factors. In neuroblastoma, they are more likely to present with stage 4 disease. In our adult cancers, this is also true. So breast cancers are more likely to be triple negative, which has a poor prognostic factor. And in colorectal cancer, they're more likely to be mucinous adenocarcinomas, which have worse survival rates. Again, this is not true for all diseases. So in diffuse large B-cell lymphoma, patients are less likely to have the poor prognostic translocation 14, 18. And in melanomas, they're more likely to have a BRAF mutation, which is associated with lower mitotic rates and thinner tumors. Another factor we need to think about in this population are familial cancer syndromes or subsequent malignancies. So in the patients who have familial cancer syndromes, like for breast cancer, those who are associated with BRCA1, BRCA2, or P53 mutations, they are more likely to occur at a younger age. However, it is important to remember with breast cancer that most AYAs do not have a family cancer syndrome, but it is important to look into. Additionally, with breast cancer, these can develop in survivors of childhood cancer who are treated with trust radiation, and this again occurs at a younger age. For colorectal cancer, there's it's patients who have FAP or other hereditary non-polyposis colon cancers are more likely to present at a young age. In addition, colorectal cancer that occurs in childhood cancer survivors treated with abdominal radiation tend to occur in the AYA age range. Thyroid cancers, or approximately 3% of these, are subsequent malignancies from childhood cancers. Another problem with survival is increased toxicity that we see in our patients. So there are many different things like epigenetic factors, changing volumes of distribution, protein binding, hepatic and renal function, and obesity that can cause increased toxicity. And we know that higher doses are sometimes needed to be treated. And if patients can't tolerate this, it leads to dose modification. Some of the toxicities that we know that are more common in the AYA population include neuropathy, osteonecrosis, glucose intolerance, pancreatitis, nausea and emesis, renal toxicity, thrombosis, and pain. However, we do know that there's less myelosuppression in the AYA population compared to the pediatric population. Another cause for poor survival that we need to think about is location of care and clinical trial enrollment. We know that adolescents and young adults are less likely to be treated at comprehensive cancer centers compared to community-based centers. And this is compared to the pediatric population. In addition, they may receive different supportive care regimens. And we know that there's differences in treatment compliance and intensity in patients who are treated at comprehensive centers versus community-based. In addition, there's a difference in clinical trial enrollment. So overall survival rates are higher when patients are on clinical trials, but we know that AYAs have low enrollment, with only 2% of patients aged 20 to 39 years participating in clinical trials compared to over 60% of the pediatric population. And another important thing to remember is if patients aren't enrolled in clinical trials, we have decreased biological samples and therefore decreased research into these different genetic mutations that are seen in the AYA population. We do know there's improved enrollment in patients who are treated in AYA programs or treated at a pediatric center. In addition, we know that for some diseases, treatment on a pediatric protocol improves outcome. And this is most commonly discussed when we think about ALL and the difference between asparaginase versus non-asparaginase regimens, with a survival of 89% in patients who receive asparaginase and increased intensive treatment compared to 38 to 46% in those with non-asparaginase regimens. In addition, we know that there are differences in AML, Ewing sarcoma, and Hodgkin lymphoma on pediatric regimens. And there's also data that show that patients with Ewing sarcoma who are treated at centers that see a higher number of patients do better than those that have less experience. Another important part to think about is adherence. And there are many studies now looking specifically at AYA adherence and ways to improve adherence through things like phone apps and other processes. And when we think about adherence, it's not just pharmacoadherence. So it's also important to think about adherence to symptom management, different protocols, seeking medical help, so calling when you have a fever, or attendance and appointments. We know that AYAs have poor adherence compared to both younger and older patients, and the rates of non-adherence in this population range between studies at 27 to 60%. There's also a difference in access to healthcare. So we know that AYAs have insurance problems and often lack primary care providers. So the highest percentage of uninsured Americans is in the AYA age range. You can see that in those less than 18 years of age, uninsurance is at approximately 5%, and in older Americans, it's at 9%. But for ages 19 to 25, it's 14%, and 26 to 34, 16%. And we also know that no or public insurance is associated with increased mortality. Often these patients will present with higher stage disease, and even those with the same stage may have independent risk factors for mortality. For example, lower SES status has been associated with increased risk of death in AYAs with private insurance and all AYAs aged 25 to 34 years. Finally, we need to think about different psychosocial stressors. AYA is definitely a different time of life, and there's a lot of uncertainty about the future. We know that AYA patients who are maturing appropriately before cancer still report decreased ability to hold a job, complete their education, and maintain relationships after their cancer diagnosis. Some of this is thought to be due to slow development psychologically or some regression. Now we're going to move on to the late effects of cancer therapy. So when I think of this picture, I always say that this is the picture I quote when I'm on the airplane and I accidentally make the mistake of telling somebody I'm a pediatric oncologist and get a big groan. So this is the 5-year survival rate with percent survival on the y-axis and year of diagnosis on the x-axis. And what you can see is that our survival rate has increased from about 60% in the 1970s to over 85% currently. And what this means is that there are over 465,000 Americans who are childhood cancer survivors. The top 3 cancers among survivors are acute lymphoblastic leukemia, brain tumors, and Hodgkin lymphoma. However, we do know that these survivors can develop late effects. Late effects are broadly defined as consequences of cancer and its treatment that manifest either during or after cancer treatment and persist beyond the end of treatment. As time from treatment increases, we know the risk of death from recurrence decreases. However, the risk for late effects increases. And this graph that's here on the slide shows the cumulative mortality in 5-year cancer survivors who were treated between 1970 and 1986. On the y-axis, there's cumulative mortality, and on the x-axis, there's time since diagnosis. What you can see in the gray line is just death from external causes. However, in the blue line, it's death from recurrence or progressive disease. And you can see that this continues to increase until about 10 to 15 years after diagnosis and then really plateaus off. However, death from non-recurrence, non-external causes, so this would be late effects or other medical conditions, continues to increase in time, and at about 30 years after diagnosis becomes the most common cause of death in survivors. At 30 years from diagnosis, the risk of having one or more chronic conditions or late effects is approximately 75%. And the risk of a severe, life-threatening, disabling, or fatal condition is approximately 40%. It's also important to remember the recipients of transplant have a nearly fourfold risk compared to those treated with conventional therapy. So a lot of us are wondering why. Why is this the case? And one of the thoughts is that it may be due to some accelerated aging. So when we think about aging in time, we know that molecular integrity begins to decrease with increased number of cell divisions over time. And even without a cancer history, this moves us towards different disease processes and ultimately death. However, we know with chemotherapy and radiation that this course can be changed and the trajectory changes, and it leads to frailty, premature, and accelerated aging. And what this causes is early mortality. So in this graph, again, from the Childhood Cancer Survivor Study, you can see survival probability on the y-axis and years since diagnosis on the x-axis. You can see that at 30 years since diagnosis, the risk of a 5-year survivor dying is 18%. And this is obviously much more than what we typically see in the common US population. The good news is that the changes in mortality over time have improved with our changes in treatment. So there's been a 15% decrease in 15-year mortality between those survivors who were treated in the 1970s compared to those who were treated in the 1990s, decreasing from 11% down to about 6%. And the largest cause of death in this population is death from primary cancer or recurrence. And this has also had the largest improvement between the 1970s and the 1990s, which you can see, again, the 1970s are in the blue line, 1980s are in the red line, and 1990s are in the green line. There have also been improvements in death from second malignant neoplasms, cardiac and pulmonary late effects. So now I want to move on and start discussing some of the specific late effects that we can see in our survivors. So neurocognitive sequelae is something that we see that can cause problems with attention, executive functioning, memory impairment, processing speed, and learning difficulties, particularly in math and reading. And the screening for this is a neuropsychological evaluation. One of the main risk factors is radiation associated, and especially cranial radiation. This is usually evident 1 to 2 years following radiation, and is progressive due to a slow rate of skill or information acquisition and not to progressive loss. The risk factors are young age, BP shunts, stroke, hearing and motor impairments. And I think the important thing to remember is that this may cause drops in IQ over time. So the most common patients who develop this are patients who receive high doses of radiation to the brain. So those with brain tumors, head sarcomas, and relapsed ALL. Antimetabolite therapy with high-dose or intrathecal methotrexate and high-dose cytarabine can also lead to neurocognitive sequelae. The risk factors are young age and female sex. What's important to know is that global intellectual functioning is usually relatively preserved, and this can persist into adulthood. So this is one of the things that I tell our low-risk leukemia patients is the most common late effect that we see in that population. As far as ocular toxicity, cataracts are the most common late effect, and these can be caused by long-term exposure to corticosteroids, busulfan, cranial or orbital radiation. There's higher risk with increased doses of radiation greater than 15 gray or combinations of exposure. If there's been previously normal screening, patients should undergo an annual fundoscopic exam and an evaluation by an eye doctor for those who have received radiation. Other radiation-related ocular toxicities include dry eye, glaucoma, retinopathy, and orbital hypoplasia. And again, higher radiation doses lead to increased risk. As far as ototoxicity is concerned, the most common exposures include cisplatin, myeloablative carboplatin, higher doses of radiation, and then things like loop diuretics, aminoglycoside antibiotics, and surgery involving cranial nerve 8. The highest risk are those that have combined exposures that receive higher doses and are at a younger age. There's also a lot more work going into the genetics that are associated with this. Common diagnoses associated are those who are treated at a young age, like those with brain tumors, neuroblastoma, and hepatoblastoma. Screening, if previously normal, should occur annually for those less than 5 years of age, every 2 years for those 6 to 12 years of age, and every 5 years for those older than age 13. It's important to note that this ototoxicity can occur late after treatment. For the platinum-related therapy, this usually occurs earlier in treatment, and it's sensory neural loss due to destruction of the cochlear hair cells. And it's important to know that the way the hair cells are arranged, there's usually high frequencies that are affected first. Sodium thiosulfate has been studied in both the COG and SIAPULSE-6 and has been found to reduce the risk of hearing loss through antioxidant properties and forming of inactive complexes with the cisplatin. And this is especially true in those with low risk disease. For those who have radiation exposures that are increased greater than 35 gray, you can also see conductive hearing loss, tympanosclerosis, and eustachian tube dysfunction. I know as pediatric oncologists, we don't think about teeth very much, but there are oral and dental complications from our treatment. Both tooth and root agenesis can occur, as well as malformations, and enamel dysplasia, which can increase the risk for caries. All chemotherapy can increase the risk of dental complications, as can radiation. However, those at highest risk are those who don't have permanent dentition at the time of their treatment, so those treated at a younger age, especially less than 5 years, and those who receive high doses of alkylators or high radiation doses or combination therapies. I most commonly see this in our patients with neuroblastoma or patients with rhabdomyosarcoma who are treated very young. Screening includes routine dental care. Other radiation-related oral complications include dry mouth, TMJ dysfunction, and osteoradionecrosis. Moving on to some of the endocrine late effects, when we think about the anterior pituitary, there are 6 major hormones that are produced: growth hormone, ACTH, follicle stimulating hormone, luteinizing hormone, TSH, and prolactin. And we know that dysfunction can occur months to decades after cranial radiation to the anterior pituitary. 51% of survivors develop at least one deficiency, and 11% in this study had multiple deficiencies. As you can see from this graph, growth hormone deficiency, which is in the blue, is the most common, and it's actually the first to develop. However, it's important if a patient develops one of these dysfunctions to check for the others. So this takes us into growth. There are several different things that can cause decreased linear growth in survivors. Again, cranial radiation, as we just spoke about, can lead to growth hormone deficiency or hypothyroidism. And the highest risk for those are those who are at a younger age and treated with higher doses. However, spinal radiation, especially to those who are prepubertal, can cause vertebral growth plate toxicity and lead to short stature. Additionally, prolonged steroids can lead to growth plate damage, decreased endogenous growth hormone release, and decreased proliferation of chondrocytes, again, leading to short stature. For some of our newer agents, retinoids and hedgehog pathway inhibitors can cause premature fusion of growth plates. And the mechanism for short stature with TKIs is unknown, whether it's growth hormone deficiency versus growth plate involvement. However, we do know that there is some catch-up growth if TKIs are stopped. Also thinking about growth, scoliosis or hypoplasia of areas can occur after radiation. And this tends to become more pronounced during the adolescent growth spurt. So during adolescence, the regular tissues that have the non-irradiated tissues will grow as normal. However, then you can definitely see the difference in the radiated tissues. This typically occurs in patients who are treated with higher doses and at a younger age. When we think about the thyroid, hypothyroidism is the most common late effect, and hyperthyroidism and thyroid nodules can also occur. The exposures are really radiation, so any radiation that can impact the thyroid gland. However, systemic MIBG for neuroblastoma and I-131 treatment of thyroid cancer can also cause hypothyroidism. The prevalence of hypothyroidism at 20 years after treatment is 30% in those treated with 35 to 45 gray of radiation, and 50% for those treated at doses greater than 45 gray. The highest risk is in patients who are treated with higher doses, female sex, and treated at an older age. For central hypothyroidism, the higher risk is for those patients who are treated with greater than 30 gray to the pituitary. And hyperthyroidism really only occurs in patients who receive those higher doses of radiation, so greater than 30 gray to the neck. When we think of pulmonary toxicity, there are several different things. Pulmonary fibrosis and pneumatosis are two of the more common. Exposures are lung radiation, thoracic surgery, and then if you remember the Bs on our chemotherapy man when you're learning toxicities, bleomycin, busulfan, BCNU, and then CCNU. For radiation-related pulmonary toxicity, there's higher risk with higher dose, higher area of exposure, and younger age. The mechanism is likely mediated by cytokines stimulating septal fibroblasts, leading to collagen production. And in younger children, there may be hypoplasia of the chest wall or lung parenchyma that can lead to some of the pulmonary toxicity. For chemotherapy related, it's associated with combinations with radiation, higher dose, and older age. And for bleomycin in particular, it's thought to be due to oxidative damage, inflammatory cytokines, and then there's probably a genetic component. Screening should be with PFTs, and obviously we talk a lot about smoking cessation in these patients. I want to spend a little bit more time talking about cardiovascular disease because it's the leading cause of non-oncologic death in our survivors. So what we think about most is cardiomyopathy or congestive heart failure. And this is primarily due to anthracycline cardiotoxicity related to myocardial injury due to free radicals. We know that dexrazoxane or Zenocard acts as an iron chelator that can be used to prevent cardiotoxicity. There are still studies underway to determine the long-term benefits of dexrazoxane, but the preliminary data have shown that women, especially those who receive higher doses of anthracyclines, really benefit from the dexrazoxane. Acute cardiotoxicity develops within a week of treatment, and this is actually usually reversible, versus chronic cardiomyopathy, which occurs after completion of therapy. The risk for this increases with longer time since treatment, and it tends to be progressive. Often these patients will require treatment with a beta blocker. The higher risk are in those patients who are treated with increased doses of anthracyclines, also those who are treated with higher doses of chest radiation, those treated at a younger age, those with comorbidities, and there's definitely a genetic factor that's being looked at more. I think it's important to remember that patients treated with radiation alone are not at high risk for cardiomyopathy. This table really shows how we've come about the dose calculations per cumulative anthracycline dose. So doxorubicin is our main conversion factor. We know that daunorubicin is about half as cardiotoxic as doxorubicin. Idarubicin is about 5 times as potent. And then when we think about the cardiotoxicity, currently our dose conversion factor for mitoxantrone is 4. However, some recent studies have shown that the cardiotoxicity is actually more and thought to be closer to 10 times that of the doxorubicin. And so this will probably change in the next COG guidelines. Coronary artery disease can also occur after radiation, and the cumulative risk at 20 years is about 21%. Ischemic heart disease is the most common cause of cardiac death after radiation, and those with higher risk are those that have dyslipidemia, hypertension, and obesity. Other radiation-related heart disease that we can think about are pericarditis, valvular heart disease, and conduction abnormalities. So for both cardiomyopathy and coronary artery disease, screening that is suggested by the Children's Oncology Group is an EKG at baseline and an echo based on the anthracycline and radiation exposures. And this is the table that shows the timing for the echocardiogram. So every 2 years and every 5 years, and those patients that don't need screening. So moving on to renal toxicity, exposures associated with this are cisplatin, carboplatin, ifosfamide, radiation, and nephrectomy. It is important to remember that cisplatin is more nephrotoxic than carboplatin. Cisplatin can cause glomerular and distal tubular dysfunction, and hypomagnesemia may be severe. The higher risk are in those patients who receive higher doses and have concurrent exposures. Ifosfamide typically causes proximal tubular dysfunction, and approximately 5% of patients will develop significant Fanconi syndrome. High risk factors, again, are higher dose, younger age, and concurrent exposures. For radiation nephropathy, this usually develops months to years after exposures and is associated with higher doses of radiation. Screening for renal toxicity should include creatinines and electrolytes at baseline, and for those who've undergone a nephrectomy, a UA and creatinine annually. When we think about the GI system, hepatic toxicities can occur from thiaguanine, mercaptopurine, methotrexate, and radiation. This is usually acute toxicity, but there can be some late toxicities. Those at highest risk are those that have received radiation greater than 20 gray. Also, patients who receive thiaguanine during maintenance, which we don't use anymore because of this, can have hepatic dysfunction. Also, those who developed SOS during treatment, and the screening for this is LFTs at baseline. Other gastrointestinal toxicity can include esophageal strictures, fistula, enterocolitis, obstruction, and cholelithiasis after radiation. And constipation or urine or fecal incontinence can occur due to spinal cord dysfunction. And I think about this in patients with sacrococcygeal teratomas or neuroblastomas that have spinal cord impingement, especially in the very young. When we think about bone toxicity, osteopenia is something that can develop after steroids or methotrexate. This is due to decreased osteoblast activity, increased increased osteoclastic bone resorption. The risk factors include white race, gonadal failure, growth hormone deficiency, hypothyroidism, decreased BMI, decreased calcium intake, and decreased activity. We also know that radiation may damage the bone marrow stromas, but it's still most likely due to hormonal deficiencies. Avascular necrosis can occur after exposure to steroids, and 95% of the time occurs in weight-bearing joints. The femoral head is the most common, and it's often multifocal. The mechanism is thought to be multifactorial and includes intramedullary pressure leading to bone stasis. The highest risk factors are those who've received dexamethasone compared to prednisone, those who have continuous steroid exposure, older age, female gender, radiation exposure, high BMI, and white race. And also those who have, we think there's some thought that methotrexate and asparaginase may also contribute. I think this is important to remember that this is why ALL patients who are older are given prednisone instead of dexamethasone. It's because of the risk of avascular necrosis. In chronic GVH, we know that there are some long-term effects that may occur, including dermatologic toxicity, so atrophy, hypo or hyperpigmentation, sclerosis, alopecia, or nail dystrophy. Dry eyes, xerostomia, dental caries, or oral cancer can develop. As far as pulmonary toxicity, bronchiolitis obliterans or chronic bronchitis can occur. There can be liver toxicity, immune compromise, especially in those who are still receiving immunosuppression. They may have functional asplenia. Esophageal strictures can lead to dysphagia or heartburn. Vaginal fibrosis can lead to dryness, dyspareunia, or amenorrhea, and patients can develop joint contractures. Finally, when we think about subsequent malignant neoplasms, the definition of this are neoplasms that occurred greater than 2 months after therapy completion. It's the leading cause of non-relapse death in our survivor population. And at 30 years after diagnosis, the cumulative incidence of a subsequent neoplasm is greater than 20%. The most common subsequent neoplasms in 5-year survivors of cancer include non-melanomatous skin cancer, breast cancer in females, meningiomas, and thyroid cancer. We also know that multiple subsequent neoplasms are common, and the cumulative incidence of a second subsequent neoplasm is 47% at 20 years after the first subsequent neoplasm. So with treatment-related MDS or AML, this usually presents less than 3 years from therapy completion with a plateau at 10 to 15 years. And the prevalence is approximately 2% at 15 years after therapy. Topoisomerase II inhibitor-related MDS or AML is associated with hepatophytotoxin and anthracycline exposure, and usually is associated with translocations of 11q23. These typically occur 6 months to 3 years from therapy completion. Alkylating agent-related MDS or AML is dose-dependent, and it's often preceded by MDS and is associated with chromosome 5 and 7 mutations. Typically, these occur 3 to 7 years from therapy completion, so a little bit later. When we think of solid tumors, these account for approximately 80% of our subsequent malignant neoplasms and are associated with radiation. The 30-year cumulative incidence, excluding non-melanoma skin cancers, is 11% in those treated with radiation alone, 9% for those treated with chemotherapy and radiation, and 4% in those treated with only chemotherapy. The highest risk are in patients who are treated at a younger age, who receive higher doses of radiation, and those with genetic predisposition syndromes. In patients who are treated with chemotherapy alone, some of the risk factors include higher doses of platinums, higher doses of alkylating agents, and increased anthracycline dose is actually associated with increased risk of breast cancer. When we think about the solid malignant neoplasms, it's important to know that it's really dose related. So the increasing dose increases the relative risk. So you can see relative risk here on the y-axis and dose on the x-axis. This is true for most cancers except thyroid carcinoma. So thyroid carcinoma is that kind of light blue line. And what you can see is that the thyroid is really dose responsive up until about 20 gray. And then there's a decreased risk. And this is thought to be due to the fact that there's a decrease and really killed off thyroid tissue at that level. As far as screening is concerned, breast cancer screening should include a clinical breast exam every year until age 25, then every 6 months. Mammograms and breast MRIs should occur annually, starting at age 25 or 8 years after radiation, whichever is last. For colorectal cancer, screening that should start at age 30 or 5 years after radiation, whichever is last, and includes a colonoscopy every 5 years or multi-target stool DNA testing every 3 years. For lung cancer, only those with high risk should be considered for spiral CTs. Skin cancer should undergo self-skin exams monthly and dermatology annually. And thyroid cancer screening is really controversial. We discussed the fact that people should really have patient discussions and decide whether palpation of the thyroid annually versus an ultrasound every 3 to 5 years is better for the patient. Finally, we're going to end up by talking about fertility preservation. So I want to start by talking about the reproductive late effects that can occur. So in both males and females, there can be central disorders, including precocious puberty and gonadotropin insufficiency. In males, primary disorders include hypoandrogenism and oligo or azoospermia. In females, you can see acute ovarian failure or premature ovarian insufficiency. Sexual dysfunction in males can include retrograde ejaculation, anejaculation, or erectile dysfunction. And in females, you can see dyspareunia. Structural disorders in females, so vaginal fibrosis or stenosis, uterine vascular insufficiency, or uterine growth impairment, can lead to low birth rate, premature birth, malposition of the fetus, or fetal loss. Some of the risk factors include organs involved in the cancer. So if you have testicular cancer, this may impact the testes, obviously. The type, dose, and combination of cytotoxic therapy. Sex, so males are more sensitive than females. Age in females, so younger age is protected in females. This is not the case in males. And there's probably genetic factors, but this is currently unknown. So the risk in males for central disorder include brain surgery or radiation to the hypothalamus or pituitary. For primary disorders, risks include orchiectomy, pelvic or testicular radiation, and alkylating agent chemotherapies. And for sexual dysfunction, it's pelvic surgery, which can include retroperitoneal lymph node dissections, cystectomies or prostatectomies, spinal surgeries, or pelvic, bladder, or spine radiation. In females, again, central disorders can occur after brain surgery or radiation. Primary disorders can occur after oophorectomy, abdominal, pelvic, or spinal radiation or alkylating agent chemotherapies. Sexual dysfunction can occur after spinal or pelvic surgeries, especially hysterectomies, uterine or vaginal radiation. And the structural disorders tend to be after either vaginal or uterine radiation. When we think about gonatotoxic chemotherapy, we typically will convert traditional alkylators to the cyclophosphamide equivalency dosing, and you can see the factors here. There are agents without conversion, so temozolomide, dacarbazine, bendamustine, and then the heavy metals. And while they're not really cutoffs, we do know that higher doses of cyclophosphamide equivalency doses typically have been associated with increased risk of gonatotoxicity. The highest risk males used to be thought to be 7,500, and it's now thought to be closer to 4,000. For females that are prepubertal, highest risk are for those who receive over 12,000 CED, and for postpubertal, it's greater than 8,000. So when we compare gonatotoxicity in males and females, it's important to remember that females can maintain gonadal function at higher cumulative doses, so the risk for gonatotoxicity is less. In males, the Leydig cells, which secrete testosterone, are fairly resistant, and however, the Sertoli cells and germ cells are very sensitive. And in females, the stromal and germ cells are equally affected by therapy. So what that means in females, there's usually concurrent endocrine dysfunction and infertility, while in males, there's usually preservation of endocrine function, but problems with infertility. In males, pubertal status does not provide protection from gonadal injury. In females, prepubertal status is protective. And in males, there will be recovery of function after therapy, and then gonadal function is stable with aging. However, in females, similar to the general population, there's a reproductive window followed by, in some cases in our females, premature menopause. So fertility preservation for males and postpubertal males, which is Tanner 3 or higher, the standard of care is sperm cryopreservation. This is typically through masturbation. However, in patients who have an impairment, electroejaculation or testicular sperm extraction can occur. Experimental measures include testicular cryopreservation and reimplantation or grafting of testicular tissue. However, remember, this is not possible in patients who have leukemia, lymphoma, or testicular tumors because you don't want to reimplant cancerous tissue. In prepubertal males, the only experimental option is testicular tissue cryopreservation. Gonadal shielding from radiation may reduce exposure, and there's no evidence for hormonal gonadal protection. In females who are postmenarchal or postpubertal, oocyte and embryo cryopreservation are the standard of care. However, there's a delay in treatment and obviously a big difference in cost. The older methods used to delay treatment 2 to 3 weeks. Some of the newer methods may have less delay, but there's still a delay that often our patients can't have. There is new designation of ovarian tissue cryopreservation as standard of care, with best results with orthotopic transplantation. Hormonal suppression with GRNH agonists for fertility preservation is controversial. And while it may reduce the risk of premature ovarian insufficiency, it's important not to replace other possible fertility preservation methods if those are options. For prepubertal girls, the standard of care, again, a new designation is ovarian tissue cryopreservation. However, there has been limited success for future pregnancies thus far. Gonadal shielding or ovarian transposition may reduce exposure to radiation. However, after oopexy, the ovaries may need to be repositioned, and patients sometimes will require IVF afterwards. Fertility and evaluations in survivors. The definition of infertility, which we didn't discuss earlier, is unsuccessful in becoming pregnant or siring a child after having tried for 1 year. So that's what makes research in infertility very challenging, because it's hard to know what patients are trying to become pregnant. However, to do a fertility evaluation, males should be offered a semen analysis, and remembering that resumed spermatogenesis can occur for up to 5-10 years after treatment. FSH and inhibin can be performed for those who are unable to obtain a semen analysis. In females, it's important to assess menstrual status. If people are interested, they can be screened with FSH and estradiol, and also they could be screened with AMH to evaluate for diminished ovarian reserve. There's also consideration of having an REI evaluation to have an antral follicle count. And in females, I think one of the important things to remember is just this curve. So this is the Fanny-Gostin curve. And on the y-axis, you can see the number of primordial ovarian follicles and the age along the x-axis. You can see that as patients aged or people aged, the kind of top line is the natural progression of having a decrease in your primordial follicle pool. And once that gets low enough, patients will go into menopause. What we know with radiation and chemotherapy is that this can actually decrease that level and the number of follicles. And then as time, you'll have a decrease in follicles. So that can lead to early premature menopause in our patients. And with that, I would like to end and thank everybody for their time and attention.